I'll use this. Yes. Good afternoon. Topic today is somewhat controversial. Uh, we have seen many drugs which came, disappeared, came back. The exact example is metformin. When we were students, metformin was a big thing. It had its brother called fenformin. We had very few antidiabetics at that time. So metformin was a big thing. Suddenly UKPDS came, said it produces lactic acidosis. Stop using metformin. Metformin went out. 20 years later, metformin make a big comeback. Now metformin, the diabetic treatment without metformin is almost unknown. We use metformin for other things also, PCODs and other things. So we have seen in our branch of medicine that drugs disappear and come back. Similar thing has happened to beta blockers in respect to hypertension. Let's see whether the current topic, how justified it is, and whether we should start considering use of beta blockers in hypertension. So, the action of beta blockers is to block the effect of endogenous catecholamines, that is epinephrine and norepinephrine. Sympathetic nervous system has been implicated in multiple diseases, especially cardiovascular diseases. It was a system which was designed for fight and flight. When we were not so civilized, we had to be chased by animals or by other wild things, and we had to have the necessary hormones to run and fight. So this system was evolved to protect us. But in the modern society, this system became bad because too much of this kind of a hormone, we realize that it produces detrimental effects on the cardiovascular system. So not only catecholamines taken exogenously, but endogenous catecholamines also were a problem in certain heart conditions, something like heart failure or even hypertension and all that. So it was realized that probably blocking the effects of endogenous catecholamines would be a good idea to protect the cardiovascular system. We all know that hypertension is one of the prime causes of causing heart failure. And that is why, logically speaking, we started thinking, why not use some drugs to block the effect of endogenous catecholamines and protect the heart system, things. So this is the person who was working on this, Sir James Black. He discovered the first drug to block the sympathetic and parasympathetic system. Before that, of course, Elquist had discovered the beta receptors. And this gentleman worked on how to block the beta receptors. And he worked for nearly 20 years. He invented the first molecule. That molecule was approved for emergency use because it had multiple side effects, but it was a useful molecule, and he received a Nobel Prize after 20 years. When he was receiving the Nobel Prize, he says, I am so excited, I can feel my heart beating fast, I think I will damage it, I wish I had my beta blocker. And that's what he said while receiving the Nobel Prize. So this is how it is. The first beta blocker was designed by him. Propranolol was later on succeeded the pronatolol, which was the first drug, and it quickly became a bestseller. 1976, atenolol surpassed propranolol as a best-selling drug. It is still available today. Metoprolol and bisoprolol were launched later on, and of course carvedilol came later also. And James Black was awarded the Nobel Prize in 1988. So with all this background, it seems logical that beta blockers should work. And for this, a lot of trials were done. So we can see all these trials. Most of these trials either used beta blockers in isolation or with other combination drugs. And some trials compared effects of diuretics versus beta blockers, calcium channel blockers, ACE, ARBs were compared against beta blockers. And some of these are the trials which said that there was some problem with beta blockers. For example, in the MRC trial, the thiazide diuretics were much better than the then existing beta blockers. Also, use of atenolol and metoprolol in comparison with thiazide diuretics did not show any great benefits. Somewhat similar results with that STOP, SHEP, TOMS and UKPDS trials, all of which were very wishy-washy in the sense the drugs were there, they were not as promising as the then existing drugs. And that is why the interest started waning in using beta blockers as antihypertensive drugs. These are some of the trials. The final nail in the coffin came from the 2002 LIFE trial, which compared the atenolol with losartan. And losartan was found to be much better in preventing cardiovascular events. This is the time when the whole thing started declining and they practically disappeared as agents to be used in hypertension. So these were the reasons why they were not being used. There was exacerbation of acute heart failure, negative chronotropic effect, beta blocker withdrawal was a problem. If you had started somebody on beta blocker, if you withdrew it, there were more problems. There was increased airway resistance, the bronchial asthma got precipitated. Peripheral artery disease, people started suffering more, hypoglycemic episodes were more, depression and central nervous system effects were there, and lipid metabolism was deranged, and weight gain was known to happen. So these are all the side effects, and this is why, plus the efficacy was not very great, and that is why the drugs started becoming less and less popular. These were some of the effects: erectile dysfunction in young people, marked hypertriglyceridemia, the effect of patients on diabetes, new onset diabetes, and of course central nervous complications. So these are the things which put the final nail on the coffin of beta blockers. So these are all the concerns. Most of them showed that thiazide diuretics, ARBs, ACE inhibitors were much better as compared to that time existing beta blockers. Messerly, in fact, he was the chairperson for the JNC 8, the Joint National Committee 8, advised that they should not be used as first-line drugs. And American College of Cardiology, AHA, and Japanese Society removed the beta blockers as first-line drugs for hypertension. We have to remember one thing: all beta blockers are not equal. This is one simple thing which everybody had forgotten at that time. Now, what was the problem? Hemodynamic problems means basically beta blockers, the then existing beta blockers, were not bringing down the central aortic pressure. The central aortic pressure is a summation of the systolic pressure and the back wave which comes from the peripheral arteries. So since the beta blockers were not producing vasodilatation, the central aortic pressure continued to remain high. And central aortic pressure is associated with strokes and heart failure. So this was the problem with, the main problem with those beta blockers which were non-vasodilatory. Of course, their efficacy in lowering blood pressure was also less. The blood pressure variations were too much because of short half-life, and there were unfavorable metabolic effects. So now if we look at these trials again, we realize one common thing. We see propranolol and we see atenolol all over the place. The same trials which I quoted before. Now I have just highlighted them. Again, if you look at the other trials, LIFE also, which put the nail, was using atenolol. Invest, Convince, all of these, the common factor seems to be atenolol, which was the then best-selling drug. So that brings us a question that if atenolol was the drug which was used as a reference drug, it was not a very specific beta blocker. It blocked everywhere. We know that there are three types of the receptors. So beta 1, beta 2 and alpha. Atenolol is not specific for any of them. They tend to block more beta, less alpha, but it was kind of a relatively non-specific beta blocker. And these are the reasons why there were these metabolic side effects, why there was lack of efficacy, and why there was the non-reduction on central of the blood pressure, the central aortic pressure. So that is why the interest came up to look at other molecules which were more specific, longer acting. They had some vasodilatory properties because they were not blocking the alpha receptors, and there were probably some better effects on comorbidities, especially things like heart failure. So when we look at a representative molecule like bisoprolol, we see that it is almost 20 times more specific than the then existing beta blocker, that is atenolol, for example. It has minimal effects on lipid glucose metabolism. It is weight neutral, and it does not affect the diabetes parameters. The HbA1c is not affected, even in the long run. Its pharmacology is beautiful. It has the longest plasma half-life. Its bioavailability is 90%. Its protein binding is limited, and its absorption is very good. So it's a good drug from all aspects. The pharmacologic variability is also minimal. So that means the peak to trough ratios are very good. The drug levels are maintained practically throughout the day. It is highly selective, and when we were looking at certain side effects, for example, erectile dysfunction, it was found to be the least affecting erectile dysfunction. So that is why we have now a molecule which we need to study more in terms of whether resurgence of these molecules can come up in management of hypertension. It is a long-acting drug, specific drug, very few metabolic effects, and very few other side effects like, for example, erectile dysfunction. So let's check some data that is available on bisoprolol and hypertension and coronary artery disease. So this was the first Indian study which got published in BMJ, which looked at efficacy and tolerability of beta-1 selective beta blocker, that is bisoprolol, as first-line antihypertensive therapy. Mind you, this is the dose, average dose was 5 milligrams, and it was found to be pretty effective. And this was the first ever done large Indian study on bisoprolol, and it was published in BMJ. Then came this paper by our none other than Uday Jhala and Tiny Nair, names which might be familiar to you. Their recent publication was a meta-analysis of using bisoprolol in hypertension, and it was found that the results were very good. It was the effect was pretty sustained. The blood pressure maintenance was very good. The numerical values of drop in pressure was also good, and it remained throughout the day. They probably had used ambulatory BPs to monitor this. So that is why, once again, some interest with 2 Indian studies coming up, showing us effectiveness and safety of bisoprolol. This is the creative study which shows the long-acting effect of BP control and using the bisoprolol versus the long-acting form of metoprolol. Now let's understand, metoprolol is a short-acting drug. It has been made long-acting by putting things inside it, allowing it to release slowly. Bisoprolol is itself inherently a long-acting drug. So there is going to be a difference. A drug which is inherently long will act better than a drug which has been potentially made into a long-acting drug. So this is the study which shows us that bisoprolol is much better in terms of sustained effect as compared to metoprolol. And this was the BISOMET study, which again showed good results in terms of beta blockade and effectiveness. Post-myocardial infarction, of course, beta blockers are an established quantity. And in heart failure, bisoprolol has a lot of evidence as compared to many other beta blockers. In fact, the whole range of CBIS studies, CBIS 1, CBIS 2, CBIS 3, COMET, all of these compared bisoprolol versus other molecules and found to be equally effective. The interesting part is that bisoprolol is a very selective drug, and carvedilol is totally non-selective. Both of these seem to work. We still don't know why it happens, but this is an observation which is just out of interest that I mentioned it. But we have enough evidence to use bisoprolol when in hypertension, when there is a comorbidity like heart failure. And we have enough evidence also there. So that is why we are bringing it closer and closer. The current rapid sequential therapy in heart failure, which the previous speaker mentioned, also says that in step 1 you use beta blockers and SGLT2 inhibitors, then introduce ARNI, then finally MRAs. So obviously if you have a hypertensive patient who is heart failure, you will definitely use, and as of interest, heart failure of both types, preserved ejection fraction also to a certain extent beta blockers work, reduced definitely it works. So even disregarding the ejection fraction, you can still use beta blockers, especially things like a bisoprolol, when you have a patient of hypertension with heart failure, which is not an uncommon combination. Different doses of bisoprolol are also effective. If you can't up titrate, the smallest dose also will work. So the effect does not go away. It's not totally dose dependent. Higher the better, but lower also works. When you talk of COPD, the drug that comes to our mind is nebivolol. Not really, because nebivolol has only one trial, while bisoprolol actually doesn't have a trial, but there have been a lot of data generated by various people to show the mortality and morbidity benefits in COPD where bisoprolol was used. So it has definitely brought down mortality and morbidity when you are treating COPD in addition to heart failure. So today, if you were to look at management of hypertension, on the left hand side you have totally uncomplicated hypertension. Here you may not use beta blockers. But as you go more and more towards the complexity of hypertension, for example, if you have arrhythmias, tachyarrhythmias, or if you have increased sympathetic activity, a basal heart rate which is high, which the India Heart Study has shown that as Indians we tend to have higher heart rates. And that is where, so when the slight complexity starts coming in, the use of beta blocker starts coming more and more inside. If you have coronary artery disease, there is no question, it definitely produces anginal relief. If you have heart failure, absolutely no second thoughts, you have to use beta blockers. And that is why, in addition, things like chronic kidney disease, smokers, aortic dissections, hypertrophic LVH, obesity, resistant hypertension, all of these places which become slightly more complex hypertensives, which are definitely there in our practice, the use of beta blockers should definitely be considered. And it has entered the guidelines also, which says that in resistant hypertension, bisoprolol or doxorubicin may be some of the few drugs which may be considered for use. And this is the India Heart Study, which was a very large study using ambulatory blood pressure monitoring, just to find out what exactly type of hypertensives India has. And this is where we found that the average Indian heart rate was much higher as compared to what we find in the West. And that is why this is another recommendation, that when you have some people with higher heart rates, higher being technically anything above 70, but 80 is probably a good cutoff. So if you have a baseline high heart rate, beta blocker therapy is definitely beneficial as antihypertensive. So this is one of the other indications. So in short, as a representative molecule, we have a bisoprolol which has highest beta-1 selectivity, 24-hour action, lowest variability, neutral metabolically, lowest incidence of erectile dysfunction, best in class BP control, very large data on mortality in heart failure, can be probably safely used in COPD, and effective in across all doses. So, and also it's a good molecule to combine. So, for example, now you will recently be seeing telmisartan coming with bisoprolol. So lots of companies within the next few days maybe are releasing. This is a good combination. So it works well with combination as well. So it is now time to now review and re-evaluate certain beta blockers in hypertension guidelines, and we must define that those drugs which we threw out because of JNC 8, we should reconsider, considering that there are new molecules available which are probably very effective in certain areas of hypertension. I'm not saying start as a primary therapy, But don't throw it away. It's not a fourth grade drug. It's something that should be considered early on, especially when you have certain specific conditions. For example, if you have a young individual with sympathetic overactivity, means high pulse rate, or those who are anxious, pregnancy, obviously you can't give ACE inhibitors. Coronary artery disease, heart failure, tachyarrhythmias, these are the subsets of hypertensives where beta blockers are effective. And the newer ones, of course, don't produce bronchospasm, they don't have dyslipidemia, they don't promote diabetes, they reduce the heart failure protection, and they have protection against sudden cardiac death. So that's why I'm just making it a case that it's not something that we have to throw it away, but please reconsider the newer ones. Thank you.
Thank you, sir, for such a wonderful session. I am sure our audience will be really helpful. This session must guide them in their clinical practice. I now request our chairpersons, Dr. Rajesh Chaubey and Dr. Vaishal Shah, to kindly felicitate Dr. Jhala, sir.